My other role is the Ophthalmology Residency Program Director, so I'll also go over the different career paths in ophthalmology, including one of an educator, which we don't often get talked to about. As Nathan said, in addition to being the residency program director, I direct our eye trauma center at Hopkins, and the residents are really are essential to the trauma center. And you heard about my path. So I did do my medical school at Hopkins, where I stayed for residency. And then I did a cornea fellowship, which is a one-year fellowship. And then I came back to Wilmer, and I started getting involved in resident education immediately as the assistant chief of service. And that's basically somebody who spends 1 year with the residents, taking care of eye trauma, staffing their cases. And then from that realized I was passionate about education, and I became an associate residency program director, and then residency program director, which I've been for, this is my 4th year. So we'll step back a little bit from education just to talk about the different subspecialties you can pursue in ophthalmology. And then in the chat, if everyone could sort of just put, I see some of you have put your year of medical school, but you can just put if you're an MS2 1. And so I think we have a mix of actually all the way to MS4. So I'll have things relevant for all of you. So as many of you know, we are a 4-year residency. And it used to be that there was 1 year of internal medicine or surgery or a transitional year. And then that was at any institution you wanted. And then you did 3 years of ophthalmology residency. Now that has changed in the last basically several years. And now ophthalmology is what we call a integrated or joint program. So currently when you match in ophthalmology, you match for 4 years at the institution that you'll be at. So most of the time, like for example, at Hopkins, if you match with us for 4 years, you'll be at Hopkins. Other places you could be associated with a community hospital, but the difference is that they'll tell you where you'll be, where you won't have the choice. So that's a change within ophthalmology. And so we got rid of the preliminary year. And so after you do your integrated or joint fellowship, which most programs are integrated or joint with internal medicine or surgery, then you'll do your 3 years of ophthalmology. Now, the one major change was that in that integrated or joint internship, you do get 3 months of ophthalmology. So that was one of the major reasons why we made the change. So early in residency, we could have the exposure to ophthalmology. So you basically now get 3 years and 3 months of ophthalmology and hit the ground running as a PGY2 resident. And then, okay, so I see in the chat, yeah, and by the way, feel free to put any questions in the chat, which we'll have plenty of time for discussion after my presentation. So I mentioned our residency is 4 years, and following residency, you can go right into practice and be a comprehensive ophthalmologist. Comprehensive ophthalmologists generally do cataracts and do comprehensive eye exams. For example, for patients with diabetes who need a yearly eye exam, they may follow some glaucoma, and generally do surgeries. Again, cataract surgery would be the most common type. They could also do some basic surgeries, like I know some comprehensive ophthalmologists who do blepharoplasties, eyelid lifts, and basic things like that. So, but then if you want to do a subspecialty, here are all the choices that you have. So probably our most common subspecialties are, I have it sort of listed. So retina is very common. That's probably the most common subspecialty that residents choose to pursue, surgical retina, and that's a 2-year fellowship. Most of the fellowships are 1 year, again, except for surgical retina and oculoplastics. Oculoplastics is also popular, but limited in the number of spots, so it's probably our most competitive specialty. For those, that's a good specialty for those of you who are interested in like ENT or plastics, but want to this is definitely an easier route to become an oculoplastic surgeon going through ophthalmology. So you enjoy sort of even more microsurgery than the plastic surgeon. And then there's glaucoma. So glaucoma specialists not only do cataract surgery, but they do specialized procedures for patients with elevated intraocular pressure for the optic nerve. Now, glaucoma, when I was a resident, it was very uncommon it wasn't as common as it is today. Now there's been an explosion in what we call minimally invasive glaucoma surgery. So the surgical options for patients with glaucoma have been expanded, and they're, as you can tell by the name, they're less invasive. and associated with less complications. So now my residents are typically each, we have 5 residents at Wilmer per year. So my PGY4 residents, I usually have 1 or 2 going into glaucoma. So there's definitely been a change and a shift there. And then cornea, that's my specialty. So that's always been popular. And then I'll talk a lot more about what a cornea specialist and the surgeries and the medical diseases that we see might be. But cataract is still bread and butter, and probably is the most common surgery that most cornea specialists do, including myself. And then less common subspecialties, but equally important, are on the bottom. So we have pediatric ophthalmology and strabismus, which is a 1-year fellowship. And there's a shortage of pediatric ophthalmologists in the US. We've seen an increase lately. It's a wonderful specialty if you like kids, and really can change the course of a child's life. And you do strabismus surgery and deal with other things, like you can do cataract surgery on children, and amblyopia management, which is involves patching and prescription of glasses for kids, which is really important so that they don't develop a lazy eye. Neuro-ophthalmology is also a 1-year fellowship, also not as common as the others, but and so there's a scarcity of neuro-ophthalmologists in the US. So if you're interested in neurology, this is a great field to consider. You'll be able to get a job anywhere. You can be a surgical neuro-ophthalmologist or a medical one. If you like more cerebral, if you like neurology and are more cerebral, you don't have to do surgery, but you can operate. Neuro-ophthalmologists can do orbital surgery for like thyroid decompressions. They can do muscle surgery, and they can biopsy tumors. So again, you can be surgical. Uveitis is also another rarer subspecialty, which is quite interesting and deals a lot with systemic diseases such as rheumatoid arthritis, which can have ocular manifestations, for example, of inflammation. And then finally, pathology is the least common and is really a dying breed, where we have ocular pathologists are scarce in the US, and mostly pathologists. Now it's more common to be a pathologist and then do some extra studies in the eye, rather than being an ophthalmologist who's pathologist trained, who's trained in pathology. But we do have an example of some ophthalmologists, for example, at Bascom Palmer. Dr. DeBovie is a retina specialist, and a ocular pathologist at Wills. Ralph Eagle is one. We had one at Wilmer for many years, Dick Green, and currently we have an ocular pathologist who's a neuropathologist by training. So if anyone's interested in ocular pathology, again, you'll be highly sought after. All right, so moving on to my love, which is cornea. It's probably one of the most rewarding of the specialties in that we have sort of instant results with many of our surgeries. It's also very precise, and our outcomes are outstanding. So as I mentioned, cataract surgery, which some of you may have seen, is probably one of the most rewarding surgeries performed in, and is the most common surgery performed in older adults. And so really, you can change someone's life overnight. And when you take off the patch the next morning, they can be extremely happy, and their vision can go, for example, from being legally blind to 20/20 by this surgery, which takes on average about, for a skilled cataract surgeon, about 10 to 15 minutes. And then we also do more complex surgeries. The nice thing about ophthalmology is, I mentioned, there's lots of flexibility. So you can do more complex surgeries, or you can choose not to. So like as a cornea surgeon now, I do some complex surgeries. I mentioned my role as the director of the eye trauma center. So I do a lot of the trauma cases, traumatic cataracts, anterior segment reconstruction, suturing of intraocular lenses. And then when we talk about corneal transplants, these are extremely rewarding surgeries that some of you may have seen. There are different types, and it's evolved over the last 20 years from the most invasive, which is on the bottom, the penetrating keratoplasty, where you have to replace all the layers of the patient's cornea and put 16 stitches in place, or a continuous running suture. But that used to be the mainstay of treatment for Fuchs endothelial corneal dystrophy, which is a dystrophy that affects the inner layer of the cornea, known as the endothelium. And we used to wait till the patients got pretty advanced Fuchs in order to offer this transplant, because it's, again, invasive, and it takes it takes several months to heal. And also, if a patient falls after the full thickness penetrating keratoplasty, even 20 years down the line, they're at risk of losing DHIS at any time. And at Wilmer, every year in our trauma center, we see, an elderly patient falling and unfortunately having a dehisced corneal transplant. So then less invasive options are shown here. So there's deep anterior lamellar keratoplasty, which is now the treatment of choice in patients with keratoconus. So you're replacing all the layers of the cornea except for the endothelium. And then for patients with Fuchs, with endothelial disease, it's evolved from DSEC, which is when you transplant Descemet's membrane and a little bit of stroma. And then even now, we just transplant Descemet's membrane. So I'll show you how rewarding that the surgery of DMAC or Descemet's membrane endothelial keratoplasty is. You're just basically replacing the layer that's affected, which is Descemet's membrane and the endothelium. And we're doing a 10 to 15 micron transplant. And at 1 week, the patients can have good vision, and then within a month they can be 20/25 or 20/20 without any correction, and there's no stitches often, or at maximum 1 stitch, so quite a difference from the full thickness penetrating keratoplasty option. In cornea, they're also doing research on injecting cells, corneal endothelial cells, as well as eye drops to promote clearing of the cornea. So lots of exciting research in the field as well. And it's all towards less invasive ways for patients to recover their endothelial cells. So I'll show you a video of the DMAC, and then, but I just want to talk about the last area, which is refractive surgery. So refractive surgery can be life-changing. So the patient's not dependent on spectacles or contact lenses, especially patients with strong prescriptions who have needed glasses all their life. If there can be LASIK, photorefractive PRK, photorefractive keratectomy, or there are other more advanced refractive surgeries that corneal surgeons can do. So you can do all of these surgeries. You can choose what you want to do. Like, I don't do a lot of refractive now just because of the way my practice is. I do more of the complex anterior segment reconstruction after trauma, but you could certainly do lots of refractive surgeries and cataract surgeries if that's what you want. And then we see a lot of medical diseases. So we can see dry eye is probably one of the most common conditions we see in ophthalmology in general. In general, a cornea specialist will see more severe dry eye. There can be dry eye associated with autoimmune conditions. We see infectious corneal ulcers, most commonly due to contact lens wear. We see all sorts of corneal dystrophies, which can be congenital, and degenerations come with age. And there can also be neoplasms of the conjunctiva, most commonly, more than the cornea. Neoplasms of the cornea are actually rare, but I do take care of tumors of the conjunctiva, including squamous cell carcinoma, conjunctival melanoma, lymphoma. So again, it's quite exciting to be a cornea specialist. So I'm going to take a break to show the video of the DMAC, and then I'm going to talk briefly about the path to apply, so you can get a sneak preview for the PGY for the MS 1s and 2s. So I want to. Can you see my the video here?
We don't see the video right now, Dr. Woreta.
Let me reshare. Okay, I think you should see it now.
Yes.
Yes.
Okay, great. So this is a
Here we show you a DMAC procedure with a video edited to highlight the key steps. The technique used here was developed by Dr. Albert Jung, Chief of the Cornea Service at the Wilmer Eye Institute, and involves a pull-through technique. The first step is to prepare the special infusion forceps and to insert the forceps into the infusion sleeve carefully and completely so that the forceps tips can open and close and the irrigation is flowing through. Next, the cornea is marked for about 8 millimeters in a region where the Descemet's membrane will be pre-stripped. A reverse Sinskey-like instrument is used to score and strip and remove the DM layer using the corneal marks as a guide. After this, a PI is made, though not shown in this video, at the 6 o'clock position, and the viscoelastic is removed from the eye. Gas is also prepared, as demonstrated in other videos, to the desired concentration, typically 20% SF6.
So this patient has Fuchs, and you could see that Descemet's membrane and endothelium that was stripped, and we send that to pathology, and it'll show what we call goutte on the endothelium. So this is why they're having a DMEC surgery. The most common indication for DMEC in this country is Fuchs corneal endothelial dystrophy.
The graft is prepared by first staining with trypan blue for 30 to 60 seconds. This tissue came pre-trefined from the eye bank. A small amount of viscoelastic is placed on the endothelial surface for protection, and then the graft is folded into a trifold configuration with the endothelium turned in and then loaded carefully onto a spoon.
So we're lucky in the US, there's no shortage of eye banks, there's no shortage of tissues. If you're rotated on like transplant surgery, you know there's a long waiting list for liver transplants and lung transplants. For corneal surgery, there's no waiting list. So I could literally do a surgery for a patient next week and get the tissue just in a few days. And it's cadaver, so patients donate it's preserved once the patient is deceased, will preserve the cornea. The eye banks will harvest the tissue. Nowadays, you can really, they're preparing the tissue more and more. So you can see in this case, the surgeon actually folded the tissue. Now you can obtain tissue that's already folded, preloaded. So all you have to do is inject it in the eye. So there's also been a revolution in sort of eye banking in the US that's making it easier and easier to do these surgeries.
The graft is then pulled into the eye using the infusion forceps. The infusion forceps are manipulated to ensure that the graft is completely inside the anterior chamber and then gradually opened and centered. This might require twisting the forceps side to side to facilitate opening of the graft, and periodic bursts of fluid through the irrigation sleeve can be utilized to help facilitate opening of the tissue as well. Occasionally, tapping the graft from the outside is helpful to facilitate centering. And
so you can see we're dealing with a tissue that's about 15 microns in size, so it's quite delicate. And again, you can imagine the difference from what I talked about, where you would literally use a cookie cutter, remove all the layers of the cornea and put an entire new cornea on. So you can see here, there are no stitches that are placed, and then how the cornea sticks, how this Descemet's membrane sticks to the stroma is we put a gas bubble in the eye, and then the endothelial cells will start pumping, and then the patient again will recover much faster than with the traditional penetrating keratoplasty.
Opening of the tissue. Gas is then injected under the graft into the anterior chamber for tamponade. Care must be taken to not move the graft in the process of injecting the gas. The gas bubble is then reduced using balanced salt solution to an appropriate tension.
So again, very elegant, nowadays mostly sutureless and quick recovery for patients. So, all right, so now I'm going to move back into my PowerPoint. Okay, so and then again, because I just have a few trauma things. So this is like something I see not uncommonly, where somebody was at work and they get a foreign body in the cornea. It's superficial. It's very rewarding because the patient comes in with a lot of scratchiness and can't get any relief, and then we can remove this right in the office in about a minute, and the patient gets relief. We do see infectious keratitis. I mentioned corneal ulcers. This is a patient that walked into our emergency room at Hopkins and was an extended soft contact lens wearer, sleeping in her contact lenses, and she had a horrific pseudomonal infection. Is doing well now, actually. I did a corneal transplant and she regained vision, but we sometimes can deal with really terrible ulcers. Just a few words about the application cycle before we open it up for questions. We are one of the few specialties that use the San Francisco match. So we don't use ERAS or the NRMP. And it's basically just us and urology who are left using the SF match. Overall, we are considered a competitive surgical subspecialty. So the match rate for US seniors is about 80%. So if you're thinking about ophthalmology, it's good to explore it early so that, again, it's one of our more competitive specialties. We are what is considered an early match. So our match, you may know the med school, most other specialties match in March, late March. Our match date will be, it's early February now. And the application should be in like by the first week of September, where the others are about a month later. One disadvantage of our using a separate match system is there is no couples match in ophthalmology. So for those of you with a significant other in ophthalmology, you have to have special considerations and sort of vocalize that you're applying with a partner. Otherwise, there's no way for a program director to know. So again, our match timeframe now is that in early February, you'll know where you're going for your 4 years. And then I mentioned the overall match rate for US seniors is 80% overall. And then the step score is less relevant, but we used to, step 1 used to be, I think, an important factor. So it used to be 247 matched mean for step 1 and then versus for unmatched, which was 237. So, and again, I don't know how we're going to be using step 2 now, because this is the first year where we really will be having most students with a step 1 pass-fail score. But in general, to apply and successfully match an ophthalmology residency, you need 2 very strong letters from ophthalmologist. The third letter can be from another medicine or surgery rotation. You do need research typically in ophthalmology and strong clinical grades. I know many of you are from medical schools with pass-fail systems, but the sub-Is are usually graded. So we like to see honors in that. There'll also be, we do put some emphasis on the personal statement, and our SF match got rid of the traditional personal statement, and there's little questions that you can answer to try to see what you'll add to the program. So that's different. And then the interview actually, I would say, is an important, once you get in the door, I kind of think of all applicants on the same footing. So the interview actually does play an important role. And as I mentioned, for step 2, how we're going to use it as program directors is unclear, because this is the first year where we have the pass fail. But I would say that a good score won't hurt you. So I usually advise students, if you have a step 2 score, if you're a good standardized test taker and are going to get a step 2 score above 240, then you can take it. That could be helpful. If it's going to be below 230, that might actually hurt you. And then below 230 to 240 is neutral. It's not really going to help or hurt you too much. And then, so this is the contact for our ophthalmology at Hopkins. So again, I'm the program director. For those of you interested in education, I just wanted you to see that there are various levels of educational leadership. So we have a vice chair of education who oversees medical student, resident, fellow education. We also have associate residency program directors, which is almost like a stepping stone to being program director. And as I mentioned, I did that for 5 years before becoming the residency director. It's great to give you sort of an idea of what the job entails, and if it's something that you think you would want to pursue, being the actual residency program director. And then all schools have a clerkship director, or they may call it a medical student educator. So they're responsible for the curriculum for the medical students. And that's also a great role where you can influence and mentor medical students, and it's very rewarding. All right, so I want to have time for questions. So I think we have about 25 minutes. So please feel free to unmute yourselves or put the questions in the chat.
Yeah, thank you so much, Dr. Woreta. I think I speak for everybody when I say that was super informative. Those cases were really interesting, and I really appreciate everything you were saying. In terms of some logistics for the questions, just since we have so many folks here in the Zoom call, if you would go ahead and raise your hand or type your question in the chat, and then I will kind of shout you out and you can have the chance to pose your question to Dr. Woreta. I see Sinan already has his hand up. Do you want to go ahead and ask your question?
Sure, thank you. Thank you for that talk. I just had a question about research and your experience recently, especially with COVID. How has your experience been in terms of your subspecialty? Has there been anything that has caught your attention that you found interesting? You mentioned the DMEC and the transplants like that. I've come across in solid organ transplants that COVID may have an increased risk of rejection or related types of things happening. Have you seen anything like that in transplantations in the eye? And if so, how has that impacted your practice?
Yeah, great question. I think there have been some case reports of rejection. So one of the risks of corneal transplantation is rejection. Fortunately, it's because the cornea is an avascular tissue, our rejection rates are low, but they are highest for the full thickness penetrating keratoplasty, and they're lowest for the DMEC. So unlike other organ transplantation, because the cornea is avascular, when you do have a corneal transplant, a lot of patients ask, do I need, lifelong immunosuppression? And the answer is they don't need systemic immunosuppression for most type of corneal transplants. The one exception will be limbal stem cell transplants. Sometimes those patients, if it's not like from the other eye, they do require immunosuppression. But for the ones that I showed you, it doesn't require, because the cornea is avascular, it doesn't require systemic immunosuppression. You use topical steroids to treat after the transplants. And for full thickness corneal transplants, you can treat with topical steroids for forever. So you may see our patients on like once a day topical prednisolone acetate. That's not uncommon. For DMEC at 1 year, sometimes patients can discontinue their steroid altogether. So with COVID, we did find there's some case reports of, or even with vaccination, there's been with vaccination, there's been there's been a few case reports of like rejection after the vaccination. So I think it's just something we carefully watch. And fortunately, most episodes of rejection can be just treated with increasing the topical steroids. So I would say that's the thing. It's more associated with the vaccination rather than COVID itself. And then again, rejection is treatable. So it's something that hasn't really affected my practice or the volume of corneal transplants I'm doing.
All right. Saima Khan, do you want to go ahead and ask your question?
Sure. And also you pronounced my name like perfectly correct, and that was amazing because that never happens. So I'm Saima. I'm a third-year medical student from Dell Medical School. I'm also one of the co-presidents for Ophtho Interest Group this year. So I noticed you are the director for the eye trauma at JHU. And that's something I'm really interested in. And that's something that I've heard from some of our students that they're also interested in. But I haven't noticed a lot of opportunities to get involved in eye trauma. It's not a specific fellowship. So do you have any advice for students or any advice during residency selection about how to have more exposure?
Yes, absolutely. So actually, Wilmer, we used to have our own IED. There's only 4 eye emergency rooms left in the country, and that's at Mass Eye near Bascom Palmer, Wills, and University of Alabama at Birmingham. So now we're integrated into the main ED. Residents across the country are involved in the emergency care of patients. And so for example, at most hospitals, it's the residents who are taking the either at home or like in our program, in-house call. So as a resident, you'll be very involved with taking care of emergency and trauma patients. For us, we're a designated eye trauma center for the region. So we do take care of, we have a lot of patients with open globe injuries, lid lacerations, orbital fractures that we see. So when you're looking at applying for residencies, you can, ask about the trauma volume. And then the other thing I would encourage you as a medical student, we do have the American Society of Ophthalmic Trauma, which I'm actually the president of, and that we welcome med student members and resident members. So you can certainly join, and we have lots of initiatives and have an annual meeting to discuss ophthalmic trauma. Now, it kind of is, because trauma is, it's not really thought of as its own subspecialty in the US, and so it kind of spans all subspecialties. So even if you're interested in retina, oculoplastics, cornea, neuro-ophthalmology, we should all be, know how to manage trauma patients. And so I would encourage you to join our society as well.
Thank you. That's really helpful.
I think there's a question in the chat as well.
Sure. Yeah, go ahead.
But yeah, we'll do maybe one more, and then maybe you can ask some from the chat so that we can address some of those as well.
Yeah, sounds great. Mara Crispin, do you want to go ahead?
Yeah, so I was actually wondering, there's been a recent change. I'm a second year at a DO school, an osteopathic school, PCOM. And I was curious, there was a new change where you can take step 2 without taking step 1. So I guess in my case, that would be beneficial. So since they're both pass fail, I could just take my level 1 COMLEX exam, but then later takes both level 2 and step 2 since they're scored. So I was wondering if there was any disadvantage with that.
Good question. So for DL students, I mentioned for US allopathic seniors, the match rate's 80%. If we look at DL students, it's actually much lower. So I do agree that you need to think strategically and really get advice in the process, because again, I can't think of it off the top of my head, the match rates, but it's significantly lower. So I would say that you definitely need a step 2 score, and you want to really have an excellent step 2 score. So I would even say like 245 or above, just to really distinguish yourself, just because the rates of matching are lower. Now we are encouraging programs not to, to do holistic screens and not just, sort of focus on things like scores. But I do think a good, an outstanding step 1 score for a DO student is will help them increase their chance of matching. And as I mentioned, and I'm happy to put my email in the chat. Feel free to email me. But I do think so. Our sort of 3 categories of students with lower match rates are 1, DL students. The second is international medical graduates, and the third is reapplicants. So anyone in this 3, I do say, like, talk to us, talk to as many program directors, and talk to everyone at your school, because the match rates are significantly lower for these 3 buckets.
Thank you.
Sure.
Perfect. A question from the chat from Jean. She says, thank you for the lecture, Dr. Woreta. And what do you love most about practicing at Wilmer?
It was a great question. So I do find that, actually, I did a recent study with one of my Hopkins med students, and we found that about 40% of, it varies per institution, but anywhere from like 30 to 70% of faculty stay trained at that institution, either as a resident, fellow. We didn't look at med students, but I do feel like when you're picking places to train, a lot of times you're picking them based on the characteristics, and you could be likely to join faculty. So I think in my case that's true. So I did my medical school at Hopkins, and then I felt it was a very collaborative environment. I felt very supported, and so after residency, when I went off to fellowship, I knew I would be coming back. So I think it's collaborative. I think there's lots of, I mentioned my interest in resident education. So there was a huge focus on that, where we have like an endowed professorship just to fund the position of the program director. I felt like my education interests were fostered there. And then I became the director of the trauma center. So again, this complex tertiary care pathology, I enjoyed doing it. But I would say a collaborative environment where I felt supported and nurtured was probably the reason that I'm still there. And I also enjoy interacting with the trainees a lot. So that's probably the main driving factor keeping me in academic ophthalmology. I ran out of time for my talk, so I didn't talk about the different paths, but this is probably something I didn't understand as well when I was a medical student. But you can do 100% academic ophthalmology like myself, and even within that there's so much you can do. Like you can be a 20%, like 80% researcher, 20% clinician, 50% clinician, 50% research. You can be an educator like me, so doing 50% clinical, 50% education. There's like a lot of things that you can do under academic ophthalmology. You can also be 100% clinical clinician in private practice. You can do industry, you can do a hybrid. So there's just lots of different career paths within ophthalmology. We are an industry heavy field, lots of innovations, in all fields. I talked about cornea, but there's lots of innovations in glaucoma, retina, plastics. So yeah, great.
Thank you, Dr. Woreta.
Sure.
Awesome. Another question from the chat from Matha from UTMB. She says, thanks, Dr. Woreta. What are some of the biggest challenges you see in global health when it comes to corneal diseases specifically?
Great question. And recently, actually, the American Academy of Ophthalmology, which is our national organization for ophthalmologists, had a global ophthalmology summit. So, they're actually having their second summit next year in Atlanta. So I think global health is one of the reasons I went into ophthalmology, because it's so amenable to for those of you interested in global health or international health. And so corneal disease is challenging. I mentioned in the US, there's no tissue supply restrictions or shortage, where in other countries, there are definitely shortages in terms of eye banks, and even when they're eye banks, having enough tissue for the surgery. So for example, when I went to Ethiopia after my cornea fellowship, there's a year or longer wait list for a corneal transplant. Then there's also issues of training, so that, you know, in many developing countries, the access to surgical training programs like a one-year cornea fellowship are actually scarce. So, and there's a number of reasons for the lack of tissue in terms of the infrastructure, also tissue donation. So there's a lot of things that that can be addressed in terms of corneal blindness in the developing world. So for those of you interested in global health, diabetic retinopathy is an epidemic everywhere. Glaucoma is a huge problem in the developing world. Mature cataracts are and uncorrected refractive errors are major causes of blindness in the developing world. So ophthalmology is a great field for those of you interested in international ophthalmology, and specifically, again, cornea. I think corneal blindness is the most common cause of vision impairment outside of cataracts and uncorrected refractive error. So so I think there's lots to do it. Another thing I didn't mention, like there are a lot of non-invasive options now. For example, for keratoconus, which is a condition where the shape of the cornea it becomes ectatic. There's a cross-linking, which was FDA approved in the US about 3 or 4 years ago, and it's been done in the UK. So access to that in the developing world is also rare, and that prevents progression. So a lot of issues with access and equity regarding different therapies. Contact lenses, for example, we take for granted in this country, but special contact lenses for keratoconus can't always be obtained abroad. So lots of challenges, and for those of you interested in it, the AO again has a global task force and a meeting that I met many medical students at. So something to look out for if you're interested in international ophthalmology or global health.
Awesome. Thanks so much, Dr. Woreta. I think maybe one more from the Zoom participants, and then we'll do some of the pre-submitted questions. Just to be fair to those who also sent theirs in ahead of time, we'll get some of those too. Zara from UMiami, do you want to go ahead and ask your question quick?
You also said my name correctly, so thank you for that. Hi, Dr. Woreta, good to see you again. So my question is about your role as director of the Eye Trauma Center. Touching on kind of what you said earlier, I think that it's very valuable to residents that have an emergency department on their facility or as part of their program. And as someone on the interview trail right now, that's something I really look for. But if I end up at a program that doesn't have the opportunity, what is a way that I could kind of end up in a role similar to that, where I get to work in med ed and trauma or something related to that if I don't end up at that type of program? And could you share a little bit more about how you got to that position specifically?
Sure. Yeah, I think mine came directly out of so at Wilmer, we don't have a chief resident, but we have this position, which is a little bit unique, where some programs have like assistant chief of service position, but you're actually an attending and you come back and work with residents. So some programs, Mass Eye Near, it's right out of residency that some people do like a chief year. I think there are a couple others in the country, but for us, it's actually after fellowship, they ask us to come back and spend a year with the residents. And that year was all trauma. So that's how I became interested in both trauma and resident education. Now, I do think for any program, again, residents for ophthalmology, one reason some people go into some might pick ophthalmology is it's a lifestyle specialty. So, even, as a cornea specialist, I feel like I rarely go in for emergencies. Occasionally, if there's like a corneal perforation that can't be glued and I need to do a transplant with the fellow or the resident, then I'll go in. But I really don't go in a lot after hours or on the weekends for cornea. Some special retina, there are more retinal detachment emergencies and oculoplastics. It's busier, but again, for cornea, our call is very light. So So one reason that some people choose ophthalmology is, again, compared to other medical subspecialties, it is considered a lifestyle. But I would say that, so in general, ophthalmologists don't like to take calls. So the residents do, though. So I feel like at many programs, the residents are the ones taking all the emergency calls. So although you might not get a large volume of trauma per se, you'll get emergencies. And there's this new movement for among ophthalmologists in terms of hospitalists. So there's like this new ophthalmic hospitals interest group that's been developed by KCI Institute in New York. And so they deal with the ophthalmic emergencies in the hospital. So even if you don't get the trauma, you'll still get to work with emergencies. And again, I think pretty much all residencies are accustomed to the residents working with faculty to take care of patients with, for example, ulcers, retinal detachments, all kinds of emergency ophthalmic care, because again, residents are usually at the forefront of this.
Awesome. So one question that we had submitted ahead of time asked if you could share your perspective and perception of work-life balance in the field of cornea, and then also how that's evolved for you over the course of your career and what things were important to you when creating that balance for yourself.
Yeah, so again, I think ophthalmology, I think it is a field that's very amenable to work-life balance. I remember, so when I was a medical student, I was kind of considering OBGYN and ophthalmology, and then like every ophthalmologist I met was like super happy and not so much with the OBGYN. So again, it's a great field for balance. There's not that many eye emergencies that have to go in the middle of the night. There's just a couple. So for cornea, it's essentially none that go in the middle of the night. So most things can be taken care of during office hours. So I would say the work-life balance is excellent. Now, if you go into academics, there are or private practice, you can sort of titrate your level of busyness. Like I keep busy with academic pursuits, like research with medical students and residents, and I think we're in application review season, so I have 615 applications to review for my 5 spots. So there's different things. You can make yourself less or more busy, but I would say like the number of hours I'm spending taking care of patients on the nights and weekends is limited in cornea in general.
Great.
And even ocular plastics, I mentioned, you can go through plastic surgery or you can go through ophthalmology, and it's a much easier path if you go through ophthalmology in terms of like the training, the number of years, the rigor of the training, and so forth.
Another question we had kind of in the bigger picture asks how you sort of see the field of ophthalmology over the next 10 or more years in relation to some other factors, including optometry as a field, insurance, private insurance, trends in surgical procedures. I guess anything you see maybe changing in the field over the course of our potential careers.
Yeah, so apparently, and optometry, this scope, there's been like a scope battle between ophthalmologists and optometrists, and our American Academy of Ophthalmology is super involved in that scope battle. So I think we're doing a great job. I mean, every year they have like a advocacy. It's every year in DC, our American Academy of Ophthalmology has like an advocacy day. So for example, if you're interested in advocacy and that's something where you can become really involved in, there's state societies for Maryland, it's like it's called MSEPs, where a lot of the leaders are leading some of these key scope battles. And in California, I think some of you may have seen in the news, there was some scope battle. I think it was about lasers and ophthalmology won. So I do think advocacy for our profession is important. Private equity, I think that's a trend that we're seeing it across all specialties, right? Like my husband's a gastroenterologist, and many of the practices when he interviewed, they were private equity owned. So that's a trend that's not unique to ophthalmology. And then, as I mentioned, technology is evolving. We're one of the fields where, for example, now a lot of times people do laser-assisted cataract surgery, the types of intraocular lenses that we can offer our patients every year. There are new ones in terms of trying to achieve less spectacle dependence and increase patient satisfaction. So I think we're a high, there's always new surgical equipment. And so we're, like I mentioned, for those of you interested in industry, I have some residents out of Wilmer do end up in industry and innovation. So that's something I think exciting about our field.
Great. And then one more from the pre-submitted questions. This one's a little more specific to students as they're applying. The question asks, what advice would you have for students that students don't normally think to ask about? Or maybe put a different way, is there something that as you're having conversations with students as they're getting ready to apply, you feel you're commonly sharing with students that they should be thinking about?
Yes, I think, and so there was a question which I do get a lot, and I advise students on about the research. So I think like some fields like neurosurgery, you have to take a year off and do research. That's not necessary in ophthalmology, but we do like to see that because again, it is a competitive field. We do research is one way to distinguish yourself. So sometimes we'll see a student is like clearly destined for another field, and you'll see they switch to ophthalmology, which is totally fine. That doesn't necessarily mean you need to take a year off, but as soon as you know you're interested in ophthalmology, you should try to obtain some research opportunities. And by research, I mentioned different, I mean, it's not, you could do education research, it can be clinical research, it can be case reports, like you just need some evidence to show dedication to the field. So there's a question about how many publications, and this is a question I get a lot, how many publications do you think are good enough not to consider a research year? So I would say that sometimes the students get overboard and they're trying to have like 10 publications. That's not really needed. So I would say it's quality over quantity. And then also like if I see like one first author publication ophthalmology, like that's more than enough. And more importantly, when you come to interview, being able to talk about it and from like start to finish, showing that you had ownership of the project, knew exactly what's going on and saw it from beginning to end is more important. Sometimes you'll see students with like submitted, in progress, submitted. And so too many of that is also a red flag that you're not able to finish. And then sometimes I hear the faculty saying, well, the student couldn't talk about the project at all, so they didn't know their own research. And that could also be pretty the kiss of death during an interview. So you really want to take ownership of the project. And if you think about it, like, so the faculty may initially give you the idea, and if you have ideas, you can certainly bring them to faculty. But once you have the idea, like just run with it, and then do all the research on it and think outside, like in other words, don't just do what the preceptor tells you, kind of think about it yourself critically and bring up new ideas and, critically challenge the preceptor too, because that's always impressive.
Great. So we have just a couple minutes left. I think, Dr. Woreta, if you're okay with taking a couple more questions, and then we'll get everybody out of here on time.
Yes, absolutely, Nick. And I'll just try, there's a couple questions in the chat that I'll try to answer quickly. One is, I was wondering if MD PhDs have the option of pursuing a research year after internship. So I would say not really, but because of the 4-year structure now, there's less flexibility there. But I would say MD PhDs at places, highly academic places were very sought after. For example, like I don't think there are a lot of MD PhD applicants out there. So places like Wilmer, for example, love that. But you can, even though there's not a year that you can take off, there are things that you can do to prepare yourself during residency. And like the internship I mentioned, you get, it's the internship in general is because there's 3 months of ophthalmology overall, you can use that and you'll be at the same institution. So you can use that year to kind of learn how to set up your career as a physician scientist. And so we've had residents work in the lab throughout the residency. A lot of programs have elective times. There are also some programs for physician scientists like at Hopkins, which are not year-long programs, but they're programs that you can take like throughout the training. So I think that would, and then I think the most important thing is to think about the mentor, because when the mentor in the field that you're interested in, because if you start thinking about it as a resident, thinking about the research ideas, as soon as you finish your residency and even during fellowship, then you can think about the early career grant support. We didn't have time to talk about grant support, but you definitely, if you want to be a academic physician scientist, you definitely want to think about grant support, because there are lots of opportunities available early in your career and the first 5 years, and you don't want to miss them by, not knowing that these opportunities are present. For example, mentored career awards are, I mean, you can actually get them anytime, but I think during the first 5 years is the most common time to get these awards. So you want to kind of know all the different pathways. And there are, you'll learn this as you go through ophthalmology. There's something called the HEED retreat, which gives different careers in academic ophthalmology, from being a physician scientist to being an educator to being like an administrative leader. So you can get familiar with all of these. Good. And then one question about away rotations. How important are away rotations? In ophthalmology, it's actually like I heard in neurosurgery, for example, that you have to do at least a certain number of away. In ophthalmology, it's not as important. And most students actually don't who match in our program, for example, haven't done the away. That being said, if you're really interested in the program, it can be a great opportunity. And as I mentioned, like for Wilmer, we have 615 applications for 5 spots. So, if you have a real interest in the program, and I think doing it away, getting to know us is great, but it's not mandatory. And again, most of my residents, like currently, I think no one of my residents currently did a in-person away. Some did a virtual elective we had, but no actually did the away. So it's not necessary, but you can think about it and sort of talk about it with your mentors to see that, for example, if you have a significant other and really have to be in a location, it can be a good way to get to know more about the program and distinguish yourself. I see a couple hands still up.
Yeah, I was thinking we'd hit Muhammad's question and then Hassam's and then wrap up. Muhammad, go ahead.
I really appreciate it. Thank you so much. I'm a first-year medical student, and I've been trying to get as much shadowing experience as I can. But how do you, aside from observing, how do you truly see that the field is for you? Because I've seen that the procedures are so specific, and it seems much more like an art at times. So how does one truly find out whether the field is for them?
That's a great question. And I remember, being a medical student, kind of thinking about this, because you do a lot of observing in ophthalmology, as you mentioned. And sometimes I shadowed a retina specialist who saw 50 patients, and, it can be overwhelming. So I think oftentimes in the summer between your first and second year of medical school, many people have a research research month, or 6 to 8 weeks or so. So I would say use that wisely, consider doing research in ophthalmology, and then also, use that time to sort of build continuity with. And so maybe for example, I have students join me in the OR every Monday during the summer. So then you can get more exposure to the types of cases we do. Now, microsurgery, it's definitely delicate. So some places have wet labs, for example, at Hopkins, we have a wet lab, and sometimes you can go in there and look under a microscope and, learn how to set your pupillary diameter and see if you like working in a microscopic setting. I have a twin sister actually who's a gastroenterologist, and I remember she did research in ophthalmology her first year, and then she said it was too microscopic, and now she does GI, which is macroscopic. But so you can get an idea whether you like the delicate microsurgery. Go to the wet lab, try to get to the side scope of the microscope and see if it's something you enjoy. I enjoyed the precision of the cornea surgery. So. But then, at the end of the day, it's I talked to lots of ophthalmologists, and again, I saw the career satisfaction was was really high. So at the end of the day, that's why I, in addition to the international ophthalmology and the high career satisfaction, that's why I chose it. And then I mentioned, there's a lot of different things you can do in ophthalmology. I know some people who ended up not liking surgery, and you can be a medical retina specialist where you don't do any surgery, or you can be a neuro-ophthalmologist where you don't operate, or if you like to operate, you can do our surgery heavy specialties. So I do kind of think that, there's something for everyone.
Thank you, ma'am.
Sure.
Great. Hassam, you want to wrap us up?
Yeah, thanks, Nick. Thank you, Dr. Woreta, for the great talk. As always, it was a pleasure. And then I just have a quick question. Regarding letters of recommendation. I know the general consensus that I've heard from a lot of program directors and faculty has been at least 2 letters from ophthalmologists. And then the last one's always a toss-up. From some, I've heard that you should try to have a 3rd ophthalmologist. From others, I've heard you should try not to have an ophthalmologist, as in both ways. Some people feel very strongly. So how do we tackle that going into the application cycle? And what are your own thoughts on that?
Yeah, absolutely. So great question. So the reason I usually say for 2 for ophthalmology is because the ophthalmology letters tend to be more research-based. Now, you can shine in the clinical setting in ophthalmology, but it's just not as easy as internal medicine or surgery, for example, because like our exams are so specialized and our clinics are so fast-paced. So, although, you can notice if a medical student is doing a great job in terms of being helpful, establishing a rapport with patients, it's hard for them to really wow us with the presentation, right? Because we're pretty, it's pretty short and focused, and and again, it's hard to like impress subspecialists. So I would say, being proactive about reading about the patients you've seen, finding opportunities for like a case report or research is the way to distinguish yourself. So they tend to be kind of less clinical, but I mentioned there is the internship, and so and then as a sub-I, you can certainly distinguish yourself in terms of how you are with patients, follow up, ownership, all that stuff. So that's why I think that letter is important. So I usually recommend to the students to try to do a sub-I in either medicine, if you're interested in surgery, or peds, for example, in one of the major ones, and get a letter based on that. So, more than just a week with one attending, but usually a couple weeks. And so that will be like a testament to sort of the clinical skills. Now, I didn't mention for the integrated internship or the joint internship, you're automatically guaranteed a spot in the internship once you match in the ophthalmology. So it's more for us, the letter, rather than the internship, but it's just to show that, you're good with patients, that you thrive in the wards, that, you take ownership, and, so yeah, that's why I recommend a clinical letter. Because what I don't want to see is 3 research letters, for example.
Absolutely. All right. Thank you so much, Dr. Woreta.
Great. Good to see you.
Thank you so much, Dr. Woreta, for your wonderful talk. And thank you all to everyone who came. And I know we're running over, but we're so grateful to have you in this program. We do want to ping our next event, which is on glaucoma with Dr. Thomas Johnson from Hopkins. And so that will be on Wednesday, November 11th from 7 to 8 p.m. Eastern time, so a later start time. And he'll be discussing glaucoma, as well as starting a community vision screening program, as well as his basic science research. Future sessions of our virtual curriculum will also hopefully be on retina, oculoplastics, global ophthalmology, pediatrics, and other things. And we are, as in the past, we'll try to get people who are from other schools, non-Hopkins. In the past, we've had Dr. David Friedman from Mass Eye and Ear, Dr. Tamara Fountain at Rush, and Dr. Michael Chang at the National Eye Institute. So stay tuned for that, and we're so grateful to have you, and so grateful again to Dr. Woreta for this wonderful talk.
Thank you so much again, Dr. Woreta. We really appreciate your talk. It was wonderful. Questions about whether or not the recording will be sent out. We are going to be sending out the recording. So if you have friends or peers that missed the session but want to learn more, we will be sending all of that along with the Google form for the next session sign up. Thank you all again for joining us. We really hope you guys learned something, and we hope to see you guys at our next session.
Thank you again to our organizers, and I'm so glad to see everyone. So there's so much interest in our field. So thank you all.